All right. Cindy, what time you got?
We're talking about the Dallas Cowboys.
Oh, yeah, it's craziness, but she's doing well.
Okay. The board secretary has 8:30, and therefore it's 8:30. So time to call to order. Okay, the first thing we have, we don't need a roll call. I can see we have a quorum. Curator Farmer is en route. She had a plane canceled. She will be here. Cindy, what's our arrival time?
She said at 9:30.
Okay, and is she arriving into Columbia?
St. Louis, and then she's driving in.
Is she going to arrive here at 9:30, or is her flight? Okay. So I would like to have a resolution for an executive session of the Board of Curators meeting because first, can we have that? Second?
Second.
Okay. Cindy, call the roll, please.
Curator Burnsick?
No, I have to call the roll on this, don't I? Okay.
Curator Burnsick?
Yes.
Curator Chapman?
Yes.
Curator Graham?
Yes.
Curator Lehman?
Yes.
Curator Phillips?
Yes.
Curator Snowden?
Yes.
Curator Steelman?
Yes.
Curator Sunvold?
Yes.
Thank you all. And now it is time we're going to start off with the Health Affairs Committee, which is Curator Sunvold. Curator Sunvold, it's yours.
Thank you, Chairman Steelman. We'll get started. We met, Health Affairs Committee met last Monday, a week and a half ago. Joining us today is also Ron Ashworth besides the curators. I don't know if Teresa is here or not. She's not here. So we'll get started. In your packet was a quarterly finance report, written report only, unless there's questions. I do also want to introduce Mike Blair. Is Mike here? Mike is the new CFO of Missouri Health. And if we have any questions, Mike can come up and answer those. If not, we will move on. Next is our compliance report. Jennifer May will come up, and Jennifer has laryngitis. So Robert Hess may come up and help if needed. We'll have her speak as she can and closely to the microphone.
Yes. Thank you, Curator Sunvold. I appreciate it. Thank you, and I apologize for my voice this morning. So we will be brief with the compliance report. You have all the materials in your packet, so the presentation I'm going to go over just really is a way to highlight and summarize the items that you have in your packet for you, and happy to entertain any questions as we go through. So just as a reminder, our reporting period, again, runs very conveniently on a fiscal year. So at the end of next week, we will be at the end of our second reporting period under the Corporate Integrity Agreement. So that you have in your packet an outline of activities and summary. This was a document that the board had requested last year, a kind of a tracking document of all the items that are listed in the Corporate Integrity Agreement that have requirements for us and the due dates for those requirements. And so you've got an updated version of that for this year. As you see, most of these things are still in progress. By design, most of them finish out by the end of next week, by June 30th. There are a couple of items that do carry forward, the primary one being the claims review that will start on July 1st. Our independent review organization and our OIG monitor require that we have a full year's worth of data to provide to our independent review organization. So that's why that doesn't start until July 1st, right after the end of the reporting period. We'll be providing that data to our IRO. They will then pick the sample from which to choose from and conduct the claims review at that point. They should have everything back to us, though. The results of that claims review will be included in our annual report, and that will be due August 29th. So we have a couple more months of work here right at the end of the reporting period where we wrap everything up, put it into the report that we provide to the OIG. And then send that off. So that is this is our tracking document and is available whenever you need that. But wanted to give you this update on it today. You also have in your packets a memo from me just reviewing everything that we've talked about here or at the Health Affairs Committee meetings throughout this past year during the second reporting period. So you have just a summary of all the items that we reviewed. Obviously, those would all be in your packets, and we can provide you back any copies of those that you might need. So that's really it on this first page, is kind of summarizing where we're at. So in review of the full year, I've got a memo document for you as well in your packet, which is a little bit deeper review of the slides that I'm going to go over here in a second. So you've got a few extra items in here for you to take a look at. But it's essentially just want to give you an overview of what we've done throughout the year. This is organized largely around those topics that you see that are required to be reported out under the CIA. So we've got a review of our activities of our Executive Compliance Committee. They met 10 times this year. They also reassessed our subcommittee structure and reviewed regularly the CCO position. A variety of topics were discussed with that committee during each one of their meetings, and some of the examples are there for you on the slide. We also have an update on our hotline reports. Our ethics and compliance hotline and our bias hotline are transitioning to a single hotline. That is in process right now, working with internal audit. Michelle Peranio and her team have led that particular project, and we're going to be a part of that as well, where we'll be transitioning both of these two hotlines into one, starting hopefully in the next few months or so. So it'll be a lot more convenient for our staff. They'll have just one phone number to call, one place to go, a little easier to remember. They won't have to try to figure out which number to use, so that'll be much more convenient for them. And so that should be coming along very soon. We'll keep you posted as that moves forward. We'll have lots of communication around that to all of our staff as well, once that's ready to go live. But right now you can see kind of where we've ended up from last year and then year to date for both of the two hotlines that we currently have. On the training and education side, we had a number of activities this year. We transitioned, but most primarily for our staff and for their convenience, we transitioned all of our training into our learning management system that we use in the healthcare side, which is SABA. So that was really convenient for the staff. It was one place for them to go to get all of their training, not just their compliance training, but all the other mandatory training that they do throughout the year. So it was a nice way for them to be able to find everything and track everything. Also a great way for our managers to be able to track and follow through with those staff to make sure that they were completing everything on time. We had an internal deadline of May 31st to finish up. We just about hit 100% on that. We were at 98.3. We are down to 3 people that we're working with to finish up, and we expect them to either finish up this week or to be placed on an appropriate leave status. So that we expect to be at 100% by June 30th without any trouble. We also implemented some new live training programs throughout this past year, primarily driven for our managers and above on the code of conduct and some of our other compliance activities. So they had an opportunity to meet one-on-one with me or some of my staff in a more intimate setting. The groups were about 20, 25 people at a time. We've done 3 of them so far, and we have 2 of them planned for next year, where we have an opportunity to really spend some time in the code of conduct and work with them through what that could mean for their staff, how they could take that back to their teams and continue to work with that and improve the staff understanding of our code of conduct and expectations. Part of all of this was leading to our management certifications. We have about 45 individuals as defined by the Corporate Integrity Agreement that have to annually certify to compliance with the program. That process is underway right now. It's designed to kind of go at the end of the reporting period, so we're underway. We're in flight with that. Should have that finished up by the end of the next week as well. One of the big changes we made this year, too, was a change in our vendor to our exclusion screening program. In April, we switched over to a new vendor. It gives us a little bit more robust look at the various types of exclusion reporting areas that we need to check, both from the federal government, but also state government and other local entities. So we were able to access quite a few more databases, get broader information, better information, we felt like, with this new vendor. So what we did is we went through and we pushed all of our employees and all of our vendors through this new screening program. And we're working on finishing that up right now. There are about 12,000 records that we pushed through that screening program. We have about 40 more that we're working through just to make sure we're confirming everything, but at this point we don't see or anticipate any issues. So that's really good. We also completed our risk assessment process for this year, did that again in conjunction with internal audit from System. It's a great collaborative process and opportunity for us to work with Michelle and her team to talk with all the leaders across MU Healthcare and MU Health to discuss various different things they may be facing in the upcoming year. And so had about 15 different meetings where we met with leaders from across the organization, talked with them about what they were interested in pursuing or looking at over the next year, and ended up working up a draft plan. So what you have also in your packet is our draft compliance plan for FY19. So you can see the areas that we're going to be focusing on. Our Executive Compliance Committee is reviewing this document right now and asking some questions, so we'll probably be adjusting a little bit more. So we'll be giving you an update later on as this gets finalized, but I wanted you to see the draft. We're pretty close, and this is probably pretty close to where we're going to be for the year. And then from the perspective of what we did this past year for monitoring and auditing our work plan, here's a summary of what we reviewed in our work plan throughout this past year. We had 14 different audits covering coding accuracy, another 5 that were really focused on our documentation sufficiency. We have 2 reviews that we're going to continue to conduct around the 340B drug pricing program, which is a heavily regulated program that focuses on our pharmacy. And we had a variety of projects that covered a number of other areas throughout our organization. So we really feel like we had a nice broad spectrum that we covered, and we're able to meet and work with a number of people across our organization to get some good feedback on where to go, again, for the FY19. Some of the things you see on this list to carry forward because we wanted to make sure we fully look at those issues. This is, again, is the resolution language. I know you've seen this before. I want to make sure that it's always front of mind for you. So based on this particular review that I've done for you today, the materials that you have in your packet and the materials we've looked at throughout the year, I'd love to entertain any questions that you have, answer those for you, and then we'll be coming back in July and asking you to take a look at this resolution one last time and sign off on it for the second reporting period. So I just open up to any questions.
Any questions for Jennifer?
Yeah.
John?
Hate to make you talk any longer.
okay, Curity.
You've done a good job.
Thank you.
But the hotlines are
Yes.
a particularly important check, for compliance, both in ethics and bias. And on the surface, it makes a lot of sense to combine it into one hotline. But I'm curious as to whether we use external, not university, commercial hotlines
Yes.
for those that want to remain anonymous. And in combining it, hotline doesn't necessarily mean that it's anonymous. If you combine the bias hotline with the ethics hotline, you're more likely to get people who are calling to complain and need some direction with the first phone call as to what they might do next.
Sure.
So how are we going to handle that? How are we going to make sure that the ethics hotline does what it does, often anonymously, but that the bias hotline, which is so critically important for that first contact, that the person answering it or the people are trained and can differentiate in how to deal with those 2 cases, because we've had great success with our hotlines and increasing on campus the awareness and the freedom to make those calls.
Absolutely. And so that's your last point is probably the most important one, that we want all of our staff to feel very comfortable. Oh, thank you so much. We want all of our staff to feel very comfortable with reporting anything that they have a concern about, any question, any concern that they want to raise, or just an inquiry about something that they're unsure about. And the hotline is a great tool for us to do that. So one of the primary things about our hotline is it is a third-party vendor. So it doesn't come directly to anyone here at the university first. They're going to be calling in to an outside vendor that takes down the information, and that vendor is trained and has a number of other academic health center and academic organization clients. So they're well-trained and well-versed on how to talk to the reporters. That keeps it completely anonymous if the reporter wants to make it that way. They have that option. They certainly don't have to provide their name or their location, and none of that is tracked. So those phone numbers that they call in from, or if they use the online service, there is an online service as well to go in, log in, and just type in their information. None of the IP addresses are saved or any of that. And to the extent that any of that comes in, it's all at a third party, so we never have any insight into that. So only if the individual is comfortable leaving their name would we ever know who it was. And so we feel like that's a really great safeguard for our staff. Then what happens is it goes into a central repository at system, and there's a team of people that look at those and triage them out. And so part of this transition process is working with our team on the healthcare side, working with the Title IX offices across the organization, working with system and others to make sure that the right people are at the table to help triage those cases, get them out to where they need to be, and then provide the information back. Also, the system works really well because anyone who reports, either if they leave their name or not, is provided a case number, and they are encouraged to log back in or call back in to follow up, and that is a great way for us to communicate, particularly with those who don't leave their name, who want to do it anonymously, because then we can leave messages for them, and then they can communicate with that third-party vendor, answer those questions, and then we get that information back. So it's a nice feedback loop right there.
Let me stop you so
Sure.
you don't have to talk anymore. And just say that the core of my question is the skill set and the training of the people. And when you're combining someone that's used to doing ethics hotline calls and someone that is doing bias, discrimination, and may have immediate problems, maybe even calling from a park
Right.
night of,
Sure.
why don't we continue this offline? And I'd like
Sure.
to learn a little bit more about how we're going to deal with it, how we're going to promulgate to different people, students in one case, medical students or nurses and doctors in another case.
Sure.
So I appreciate your answer, but let's talk on a break.
Okay, sounds great. We can do that. I think we should get Michelle Peranio in that conversation.
Yeah. Or we can talk after you get your voice back.
Absolutely.
And you just brought up a name that I was going to ask you about, and my question's hopefully an easy yes or no. But I'm not on the Health Affairs Committee, I'm on the Audit Committee,
Yeah.
and I would assume then that the Compliance Department and the Internal Audit Department are working very closely together
Yes.
in efforts and ongoing compliance efforts and targeting audit areas.
We do. So the risk assessment process is collaborative, and then we try to make sure that our plans are complementary but not conflicting or overlapping. Yeah.
Good questions. Anything else for Jennifer? If not, thank you very much.
Thank you. And thank you for this. I appreciate it.
Next item on our agenda is Dr. Ted Choma, who just walked in from OR, I understand, has a proposed amendment on the collective rules and regulations.
Thanks. My name is Ted Choma, and I'm an orthopedic surgeon, and I'm chairman of the University Physicians Practice Group. Just a bit of background, the Board of Curators in the 1970s created university physicians as an entity to contract, bill, and collect for the clinical services on behalf of all of our faculty physicians. They updated the governing collected rules once in the 1980s, and then not again until last year. Last year, we took on the task of updating some of our collected rules, and the process for doing so means that our management committee needs to approve the proposed changes, and our entire physician membership has to vote. If we have a quorum and a plurality, then those changes get forwarded to the dean of the medical school with their approval, the chancellor, then the president, and ultimately gets forwarded to you all, the Board of Curators. We went through that process with a few changes last year, and because we were able to navigate that process, our legal counsel had gone through our collected rules and recommended some really not very contentious updates to our collected rules. And so this year, we're going through the same process. Our management committee has just forwarded those proposed changes to our membership, and we've opened electronic voting amongst all of our physician members, and we have 600 of them. We anticipate that process, the voting will close in the end of July, and if successful, and given the approvals of the dean, the chancellor, and the president, by the fall, you all may see a proposal for additional changes or updates to our collected rules, the rules that we have to live by. These changes this year are to change some of the titles because the wording included some of our officers in the health system with titles that don't exist anymore. And so we simply updated the titles from things like executive director to CEO. We also went through and took out or changed gender pronouns to make them gender neutral where possible. And then the last thing, which is a material change, was that it changes the language about what income is considered university physicians' income. It had simply said, this language was built in the era when all of our collections were fee for service, and now we have several relationships with area hospitals in which our physicians essentially we receive a contract under what's called a professional services agreement. We don't actually bill for those services. The hospital that's on the other side of that agreement does the billing and collecting and simply pays a fee for our physicians' time. And so that is going to be a growing trend. It's a growing trend nationally. It'll be a growing trend here in mid-Missouri. And although we have been acting as if that is university physicians' income, our collected rules did not specifically so state. And so, so those are the proposed changes that are going through this process. It'll probably take another month to try to get enough a quorum of votes in, and then probably a few weeks to get reviewed by each of our oversight officers. Any questions?
Questions, thoughts, ideas?
Will you have a executive summary of what the meaning of a couple of those would be, the last one being the most important?
Right.
So that we don't have to interpret
Right.
the effect of what the rule change
Right.
means to physician income.
Right, yeah. Yeah, and we'll have that language for you. We're also communicating that to our physicians. We need to be clear and sensitive to their concerns that university physicians is not trying to make a claim on other income they might have for business they do outside of their university employment.
Are there, I mean, it seems kind of obvious and clear. Are there objections so far or not?
No.
I mean, this is kind of simple.
No, it's just that the process that I just outlined to you has been considered fairly onerous, and so it's been decades since we've tried to undertake and update this language.
Any other questions? Dr. Choma, thanks, and we'll probably look forward to seeing you in September.
Right.
Next item up is the updated on the MU Health Board structure and meetings. President Choi.
Thank you. Thank you, Curator Sundvold. As many of you know, academic medical centers, academic health centers are undergoing some dramatic changes, and some of the driving forces include changes in the Medicaid, Medicare payment schedule, as well as significant competitions that are coming from larger organizations that are even for-profit. So in an effort to provide a governance structure that is both streamlined, that can also achieve operational excellence and focus on strategic priorities, we want to present the board with some concepts of a new governance structure that can achieve those goals. We've had a number of discussions with curators who are members of the Health Affairs Committee, as well as constituents within the university. So I'd like to ask Robert Hess from the OGC to present us those concepts.
Morning. I'll work through the details of where we're at on the current proposal. This is similar to what we presented to the Health Affairs Committee about a week and a half ago, but with some updates from that discussion. So just kind of put in context where we are in the process. A revision to the board level governance kind of came out of some of the dates back even to a year ago. Just are there ways we could improve, be in a better position to accomplish some of our objectives? March and April specifically, we brought the issue up at the Health Affairs Committee and the full board and had a discussion about a broad outline for redoing the governance. The charge coming out of that was to come back with a detailed proposal. I think there was general support for the concept, but we needed a more detailed proposal. So we worked on that. We met with President, Chancellor, other MU Health leaders. We brought an initial detailed proposal to the June 11th Health Affairs Committee meeting. This is largely the same as that proposal, but with some tweaks and modifications based on that discussion. So currently, what we are targeting is that with the additional feedback we get today, that we would take this detailed proposal, the next step and the final step, to putting in actual language for a collected rule change and other changes that would be needed to implement it. And then we would bring that back to you at the September board meeting. So that's kind of where we're at in the process. I'll go through the details. President Chua and Chancellor Cartwright will, can chime in on the strategy and the details and at that level as appropriate. So really kind of what we're trying to do is we want to take board level governance of MU Healthcare and consolidate it in one group. We've identified that group as the Health Affairs Committee. The Health Affairs Committee of the board would be substantially reorganized, as you're going to see, so it would be a little different than it exists currently. But the idea is to really focus strategy, vision, mission alignment in one group of individuals, to streamline some of the different boards and groups that we've got that share the strategy and mission alignment function currently, and it's spread out probably over too many groups currently. It's led to some redundancy and duplication, inefficient use of people's time. Ultimately, we want to enhance our ability to be a top flight academic medical center and to get mission alignment to be really great at the clinical enterprise, to be great at teaching and research. So these are the details of how we're proposing to implement it. So the first sort of major thing is committee composition. We would change the composition of the committee to have 5 at-large members nominated by the committee, and the idea is that these will be people who are really regional and national experts in healthcare clinical operations, academic medicine, that you would bring in people who already have a diversity of subject matter expertise that's relevant to running a health system, and that those people would provide balance and depth to your perspective. By bringing in those outside people, of course, we still want to have strong representation from the university. Our university representatives would be a curator, the system president, and the MU chancellor. And then we're proposing 1 slot for Capital Region Medical Center. They're an affiliate of MU Healthcare in Jefferson City, and we think it's important to have them as a member of this group. The president would serve as chair of the committee, and we'd also contemplate retaining a consultant who'd be available to advise the committee as needed. So when they needed somebody to do a deeper dive or work or bring perspective to them, that they would have that resource available.
And we stop there for a second. First, we've separated out and identified our partners and partly owned folks in Jefferson City. The committee talked about, and maybe in a public forum we ought to talk about, that shouldn't be viewed as making a precedent that every time we partner or bring a hospital into the system, that that's necessarily going to be true. They're already a part of us, and so they should be represented, but future hospitals may or may not and probably won't have representation on the board. We also, that brought on a discussion about, is the size right? And some people had said, in addition to the consultant, there may be people from out of state or people that aren't currently connected but that have expertise. Can't remember exactly what the discussion was. So did the working group consider that, and are you coming back to the original size? And I think there was a part of the discussion was it shouldn't be too big, that it could be more than 9, and it would allow for additional representation from physicians or other important components that currently don't have any real oversight on MU Health. Where has that evolved, or is it still a working draft, or has this been decided as the recommendation for September?
So my sense would be it's still a working draft. I've heard like points and counterpoints on both sides of that. I think you could adjust the representation, obviously to include more or less members. I think where we're at still is at 9, but we could discuss the others. And to your point about Capital Region, I think that's right. I think it's a structure that you could add a future representation for a health system, but it's also not an expectation that if we did, affiliate with somebody else or somebody in the future, that they would necessarily be entitled to that. A big part of that, I would say currently Capital Region does have a seat on the Medical Alliance Board, and kind of the strategy function for aligning strategy for Capital Region, the university's been conducted at the Medical Alliance. Part of this is to move all of that to the Health Affairs Committee and to give them representation for continuity, and they're an important partner in Jefferson City.
Well, if we were to acquire BJC, we might give them a seat on the board, but not Boonville.
I think that's probably a fair sort of examples on the spectrum, right?
A country boy,
those
I
are
would-
two good
as a
examples
country
on the
boy,
spectrum.
I would stand up for Boonville. I just know.
Thank you.
Mr. Chair, can I ask?
Yeah, go ahead.
And I assume there's going to be some other things coming. I don't want to preempt any questions or start on any questions that you're going to answer. What I'm interested in, and this is directed to you, Phil, but probably to you more, John, is what process are we looking at following? Because I think it's important that your committee get to do its work, but I think it's important that the whole board be able to weigh in at a particular time, and maybe then we should attend your board meeting. I'm just asking for idea on what you would foresee as the process to finalize, and by finalizing, include curator questions and amendments. I can think of a few things I'd like to discuss, but I don't know if today's the time. So what do you foresee?
I think initially this was rolled out, and we had changes from the last meeting we met. The more that it's rolled out to us, the more questions we've had to roll out to the full board. So I would think sometime in the summer, as they drop the more details of everything, because there are questions that we still have, whether it's the size, the number, or when he gets to the next diagram where the arrows point. So when we met last Monday, we had questions, just like they're being asked today, so there's nothing set in stone. I think the idea was to make it better because of the redundancy of having 3 meetings in one day with the same people, except you add 2 people in each meeting, didn't seem to make sense. So there's a lot of work left to be done, but I think to the full board, I think sometime this summer, we will probably have more detail, so that September meeting, we'll at least have it in our hands to
And I don't
go
know the health affairs schedule. Do we schedule another health affairs meeting prior to the September board meeting?
Yes. Yeah.
This is just a request, John, but let's think about, and Cindy, to you, an understanding that there will be significant work done at that committee meeting, so that board members who want to weigh in on this should attend, and maybe a little extra work to make sure it's not just work with the Health Affairs Committee, but with the full board. Because what I would prefer is that most of the work, I'm not saying we can control what goes on at this committee, but most of the work be done by the Health Affairs Committee when you have more time to discuss it. And
Yeah, good
does
points.
that sound reasonable to you?
Yeah, and it's good points, and we will have another meeting, and prior to that meeting, there'll be a lot more details that come out that we'll discuss, and then get the full board together.
Following up on that, I'd be interested in learning at this point the extent to which we have buy-in from, let's say, those affected, to what extent it's been vetted within the medical school, even nursing and health professions, so that they also have had a voice not only in our committee, but have had a voice in the makeup, because we don't want to impose something that the dean of the medical school, nursing school, health professions I know that they've been included, but I think we ought to have a comfort level that, that they've had a part in it and that there's great support for not only the simplification, but the huge change in terms of governance, because it will be big.
Chancellor Cartwright.
Yeah, we actually we had a great meeting with the leadership team, all of the people that you were talking about. President Choi was there, I was there, and we talked through this type of structure and how this would work. And I mean, I would go as far as saying it was unanimous support for going in this direction.
Perhaps I could add, Curator Phillips, yes, we did vet it internally. I can't speak for the other schools, but certainly at the level of the School of Medicine and UP, we were involved in the discussions and feel comfortable with the current proposal.
And I don't see Jonathan Curtright here, but I presume he's fully on board as well.
Jonathan Curtright is fully on board.
Yeah.
Just
Chairman Steelman.
one other thing, so that kind of what is going on is, I would say that every member of this board at one time or another has had a discussion about the need to revise and change the board's committee structure and to maybe have outreach and have some permanency and do some of the things that you're doing right now with the health affairs. So I think we should also keep in mind, it's too bad we're doing it piecemeal, but we've just had more than we can do, obviously, this year. But what you're going to set here, too, Curator Sunvold, is probably a template for how we go about doing committees for the entire board, too.
You know, I think it started, obviously, originally when our discussions were with the Boone Hospital, but on governance. And so when we looked at our own governance, we thought we can make it better. And that was the whole key. And where the number is 9 now, and that may change, obviously. When we first started, there were so many numbers because we thought they should be board members. But then we slowly qualified that to say they don't have to be board members. We need experts in the room, much like we're a board, but we have experts in the room. So whether that board says that doesn't mean that Jonathan Curtright, I mean, those experts will be in that room. So it becomes more streamlined, but the really thing is it becomes better, and better for what we're trying to think the future will be for MU Health.
Well, thank you for your work, all of you.
So, so the committee's charge, and we worked on this and clarified this a little bit, and one thing that you may, that may not be apparent from just reading the slides, is the committee's, it's really going to focus on MU Healthcare. MU Healthcare is the hospital and clinics. When we refer to the entire academic medical enterprise, we usually refer to that as MU Health, without the healthcare in it. So in going back and weighing how broadly to charge the committee, where we settled out is that we would really have the committee's focus be strategic oversight of MU Healthcare and its affiliated facilities. It would be charged with ensuring the financial success and appropriate risk management, recognizing what MU Healthcare represents for the university as a whole. But there also needs to be important coordination between the academic enterprise, the schools, the physicians. You know, to a large part, the physicians drive the success of MU Healthcare, so you don't want to create silos. So the committee will have an advising and consulting role more on that, the coordination aspect, and it can be assigned specific responsibilities as determined by the Board of Curators. So from the charge flows the areas where it would have specific delegated authority, and that's to develop mission and vision for MU Healthcare. That the committee would be responsible for hiring and terminating the MU Healthcare CEO, so we think that's important for responsiveness and alignment. To the coordination role, that consulting with the MU Chancellor and Provost and then other campuses on academic and research and strategic initiatives that are supported from MU Health. So in exchanging thoughts about how this would work, I think we really kind of, in this iteration, settled on that the chancellor is going to continue to be that key role that supervises. He's over all the parts, and that the committee would work closely with the chancellor and the president, who will be on the committee, to assure alignment across the system. And then finance, the committee would approve annual capital operating budgets, and then school support budgets, and significant financial decisions for MU Healthcare will determine kind of what's significant, but that they would have approval authority over that.
Can I ask a question? Because that's a little different than what I was expecting, because the bonding capacity, et cetera, of the university as a whole, right, Ryan? And by approving, do you mean final approval by the finance or subject to the Board of Curators? Because I will tell you, I could never go along with anything that allowed another committee to affect our bonding capacity with some of the projects we've got going. And as an example, a decision made could impact severely our ability to move forward with our TPMC, just for examples. And I think we have to guard against that.
So the current proposal, that level of detail is just not in the slide, but it would be a concurrent approval. So they would be an additional approval required, but it would still go through normal finance and the board, if board was required. So we wouldn't be divesting the board of its approval authority.
And as the CFO, how are we going to coordinate this with the system CFO and the campus? Is the plan to keep your office, Ryan, totally in the loop?
Yeah. I think it actually operationally would work a lot like it works today.
Okay.
There was a suggestion that I think had support, maybe consensus at the committee, that there be some wording. This is not detailed to put it in, but that kind of approval would be subject to the board, and if they did not withdraw it or modify it at the next regular Board of Curators meeting, then it would stand. But it wouldn't be effective on something like finance unless the board actually had a meeting and didn't change it.
This is going to be debated otherwise, but we worked very hard to put a 5-year capital plan in for the university as a whole. And the health affairs, it was specifically discussed and determined that health and the health would be part of that 5-year planning process by the board. And I'm not sure whether I'm hearing a change to that or not, and I would rely on the finance chairman, Curator Burnsick, to some extent, but we have to be very careful to keep strategic oversight of our finances at the board level, in my opinion.
My understanding is that the finances would remain the same, but the operational component of managing the health system would change to, in order to have the expertise necessary to make some of those operational decisions.
The reason it has annual capital in there, and that to me is a danger point.
Probably not a decision, but a recommendation to the board.
I agree with everything you've said, and that nuance was to be a fail-safe so that they wouldn't have the authority without the full board approval. Having said that, I'll return to your point when we get to the chart, which will come up shortly.
Okay, I jumped the gun.
All right.
So then on the retained powers of the Board of Curators, the board would retain ultimate governing responsibility, and they're going to have the ability to change any decision at any time. So that's a current provision, of, I think, 20.030 in the collected rules, maybe it's 20.050, but and we'll specifically reaffirm that. So the board ultimately, if there was a decision that the committee made that they thought wasn't aligned or wasn't in the overall interest of the university, would have the ability to reach down and change that decision. We think it's very important to include that authority. You know, we also think, for all the reasons we're setting this up with 5 at-large members, that it's important that the board kind of exercise it sparingly. It would be a last resort, but the board would always retain that. The board would appoint and remove all members of the committee. It would have approval over major financial and strategic decisions, so there would be some kind of level where board approval would expressly be required. and the committee would report to the Board of Curators at least semi-annually as requested by the board, or as requested by the board, sorry. There was discussion about how frequently to do this. I don't think we've exactly hit a rhythm on that. It could be quarterly reports, written with semi-annual, verbal presentations or something like that. So, but we thought at least semi-annually. We had annual reports initially, and everybody thought that was too short. So that's something to be fleshed out. And to your point, we do intend for Finance and the Health Affairs Committee to work kind of concurrently. We're not divesting Finance of that authority, but we do need to get down and work in the details of how that would work. So our other health-related boards, so these are three of the areas where some of the duplications occurring. We've got the University of Columbia Medical Alliance, which is set up to manage relationships with outside affiliates. That's predominantly Capital Region Medical Center, Healthcare Advisory Board, and then 2 affiliates that we've created for community physician practices. The vision here is that we would consolidate the strategic decisions and discussions that occur at all those boards with the Health Affairs Committee. So we have some of these subsidiaries that were created for different purposes. Pieces of the discussion occur there, but that's where a lot of the redundancy is occurring. So we would move the strategic type discussions out of those entities into the Health Affairs Committee. They would still exist for their operational purposes, but they would be more focused on operations. The Healthcare Advisory Board would be eliminated. That was a board that was really created to advise the president and facilitate communication when the executive vice chancellor position was created. From the way we're setting this up with the president as chair of the Health Affairs Committee, we don't think we need a separate board to advise him that there'll be information flow through the Health Affairs Committee, and that the Healthcare Advisory Board could be eliminated as part of this reorganization. So this is the graphical representation we have of how we currently envision the relationships would work, and we'll of course adjust the graphic as we make further changes, but we would show MU Healthcare with a direct line to the Health Affairs Committee, and then the dotted line is there to really show that the campus and the chancellor would continue to coordinate the activities of the entire academic health center, which we have traditionally defined as the hospital and clinics, and then the 3 health schools, nursing, medicine, and health professions. And that's why we have singled those 3 out. There are lots of opportunities to collaborate with other parts of the MU campus, the vet school, the engineering school. There's opportunities to collaborate with other campuses too, and I think President Choi and Chancellor Cartwright are acutely interested in pursuing those. These 3 are just singled out because they're the traditional, what we've defined as the academic health center.
And I would say that this is a good improvement since the last chart, but I'm not entirely comfortable with it, and let me explain the 2 reasons. First reason gets back to what you're talking about. This, again, visually sets MU Healthcare as just being coordinated through the Health Affairs Committee and then on to the Board of Curators, and then totally separately you put in the MU campus and the MU health system. The improvement is you have a dotted line that acknowledges that the president and the chancellor and at least 1 curator are involved in oversight because they're part of the committee, all right? But that visually still gives you a separate MU healthcare. And there is in those schools, as I understand it, that have an academic health institution and also a hospital that provide, or often a system that provides the health care, a natural tension between the educational function and the monetary function. We experienced that off and on for the past couple of decades. Sometimes it was helpful. Out of tension comes creativity and wise spending. Sometimes it's not helpful because one or the other becomes dominant. Sometimes the dean of a medical school isn't necessarily a good executive of a hospital. Sometimes an executive of a hospital can create a great system, but not share in the good years the income that is generated from the hospital. And so we've had a problem making sure that it's managed effectively. You need somebody that can coordinate that. Sometimes it works well, sometimes it doesn't. But you're really taking that individual or that position out of the equation here. And in fact, the committee will have 3 university folks on, a curator, a president, and a chancellor, but only 3 out of 9, right? So unless you've got a strong president, and we've got one, so in the foreseeable future, that probably is satisfied. You could have a health affairs committee that runs amok and does not coordinate well with the med school. So visually, you know, the dotted line takes care of that, I suppose. So that's the first nuance that this doesn't quite help me, although I could live with it. The second is, and I've said this before, and I'll use the example. When I was first curator, I learned in the papers that the MU Healthcare had gone ahead and decided that they wanted to put another hospital, I don't know, someplace south, close down Fulton, although it wasn't stated, and apply for a CON. And that didn't come to the board for approval. It just happened. And I learned about it in the newspapers. I didn't learn about it at a board meeting. And I think that may have changed the dynamics of the BJC MU healthcare relationship, or I should say Columbia relationship. I don't live here, but I think it was difficult for the committee, for the community to work through that. And that's how independent MU healthcare was. It was that independent. And they weren't sharing with med school appropriately. Fast forward 5 years, and because of the visual presentation here, would MU Healthcare and the Health Affairs Committee, dominated by 6 people who aren't in a fiduciary capacity because they don't work for the university and they're not on the board, would they decide to sell to some, let's say, HCA, right? And say, well, we'll take $5 billion for that institution. It ultimately would have to come to the Board of Curators, but I would hope that the board wouldn't have to learn about it through the newspaper. So visually, this sets it apart and doesn't show that the health professions, and I mean that the med school, the nursing school, actually the health professions and others that are now going to be collaborating even more, that there is a partnership between MU Healthcare that is going through the system. It isn't going just to the Health Affairs Committee. So that's my other objection. Having said it, this is the best since the first one. The first one had them together and went through the campus appropriately, the system, and then to the Health Affairs Committee, and then to the board, which to me made it clear that they're still going to have to play together. So I don't know. I'm running on here, but I can live with this. But I guess give it some thought.
President Choi.
Before me, how about Ron?
Well, 2 comments to that. I think to satisfy everybody about this change, we have to have a specific delineation of the reserve powers of the Board of Curators on all matters. And that includes all the finances that you were talking about, Dave. And it includes the strategic plan. It includes any major transactions that would take place. It has to be clear that those have to be approved by the Board of Curators. So a reserve power listing in this would be typical and something we should be very specific about. Second thing is the people aspects of situation will determine what happens in any dynamics. That situation you're talking about 5 years ago existed under the old structure. You got to have the good people that are communicating with each other, no matter what structure you have, to make it work. But reserve powers will solve most of the concerns about what can and cannot be done through a committee like this.
Let's go to the curators first.
Curator Chapman.
So is this model proven to be effective in other healthcare systems, or did we just pull this out of the blue? Are there other examples that you could share of where this has been effective?
So there's kind of a spectrum, I'd say, of models when you look out there. People set their academic medical centers up so many different ways. It's hard to group and classify them. So some of the key things to think about is we own and operate our hospitals and clinics, which is kind of a unique position well, not unique, but it's a minority position of current academic medical centers. A lot of places have partnered with other people. Along the spectrum, then, you kind of got a lot of people set up who have their clinical operations, a separate committee just to focus on that. So that's very common. Then you have to draw the line at how far into the clinical enterprise do you want to go. So the current version is to set it over the hospitals and clinics, right? The next step in would kind of be to focus on also bringing in oversight of the clinical components of the School of Medicine, so the university physicians, the faculty practice plan, nursing and health professions, which have smaller pieces. In discussing it, we decided to focus on the hospital and clinics. The clinical leadership in the schools have a lot more shared responsibilities. They have a lot more directly balancing the research, teaching, and clinical missions. And people were most comfortable continuing to have those handled through campus, with the committee and the president and the chancellor performing the coordinating role to make sure we're getting the balance right.
Don't mean to interrupt, what I'm asking is, does Purdue follow this? Do proven successful universities with healthcare, do you have examples of where this model has worked? And
so examples I'm thinking of Illinois, Virginia have a similar sort of setup where you have a committee that's responsible for clinical operations. There's differences on where you draw the lines, I guess, on some of the second order issues. I think this is a logical place to draw it. I don't know that it's easy to benchmark it because there's so much variability about how people do it.
Curator Chapman, I'll do my best here. Much like Curator Phillips said, you have the MU Health, which is the educational academic part, and you've got the hospital. Many places will have a person above those, EVC, Executive Vice Chancellor, which we have had in the past, and really the Chancellor fills that role here now, so that they report up. The one box that would be missing to Curator Phillips could be that EVC spot that then handles both sides. So if you look across the country, it's done like this. It's done with an EVC, or it's done straight to a chancellor, or it could be the dean of the medical school wears two hats, or the CEO of the hospital wears two hats. The only thing we've looked at, and talking to President Choi, is that the EVC position currently wasn't needed, and we drew it more to the chancellor of the campus.
And the president has taken a stronger role.
Yes.
Currently. And actually the boxes that we have would accommodate, because it just says, it goes through the campus and the system, and it doesn't identify, do you have to have an EVC?
Right.
You don't have to have one.
Yeah.
In fact, you probably wouldn't want one. Now it's working awfully well with the chancellor and the president.
Yeah, it is working well. So currently we have, for clinical affairs, the CEO of the hospital, Jonathan Curtright, and for clinical affairs, Patrick Delafontaine, have a dual report to the president and the chancellor so that we can better coordinate. So now it is working. But during our last conversation, we did talk about the need to have some constructive tension between the academic side and the healthcare so that we can drive the growth, the needed growth. Going back to your comment about being surprised, I believe that this kind of structure will prevent the surprises, and it's going to be my job as well as the chancellor's to keep the board, the rest of the board, aware of discussions or thoughts that are occurring so that we get input as we come to those meetings to make decisions.
If I might suggest, we're running a little late right now, and there's a lot yet to happen. So, Curator Sunvolt, with your agreement, I'd suggest we probably move on a little bit. I would like to comment that Ron Ashworth is here today. I don't know how many of you had the opportunity to talk to Ron. We're very lucky to have his service, and Ron is very giving of his time, and there are a lot of specific questions that I'm sure, Ron, you'd make yourself available on an individual curator basis, because you always have. And so some of your questions can be answered by Ron with tremendous experience and insight.
Good suggestion, and thank you, Ron. Anything else, and we'll pick this up down the road, I'm sure. Robert, thank you. Next item that we have is the Health Affairs Committee. I need a motion to approve the April 12th minutes from our committee.
Move approval.
Second?
Second.
All in favor? Say aye.
Aye.
All opposed? Any abstentions? Motion passes. And now I need a motion to move to executive session.
I'll move.
Second. Roll call. Roll call, Cindy.
Mr. Ashworth?
Yes?
Curator Graham?
Yes.
Curator Phillips?
Yes.
Curator Snowden?
Yes.
Curator Sunvolt?
Yes.
Okay, you have all votes in favor.
Thank you very much. We now have, we're going to retire to executive session of the Health Affairs Committee and move immediately from that into a board executive session.